of general anesthesia. And the reason I'm going to do that is that we have not the foggiest idea how anesthesia works. Okay? 150 years after the first the surgery, the physiological mechanisms are really basically unknown. It is what in medicine is called a purely empirical treatment, which is a treatment that's known to be effective, but whose underlying biological mechanisms are not known. And there are some informal theories around. For example, it's been suggested that somehow the anesthetic drugs alter the dynamics of the cell membranes in neurons, or that somehow they interfere with synaptic transmission. There's another theory that suggests that they interfere with the transmission of the neural impulse down the axon. And if you think about it for a second, if you think about it for half a second, you see that pretty much exhausts all the possibilities, right? Either you prevent a neuron from discharging, you allow the neuron to just discharge, but you prevent the neural impulse from going down the axon, or you prevent the leakage of neurotransmitter into the synaptic cleft. I mean, that's basically all the possibilities there are as far as rendering somebody unconscious. And there are theories that go with all of these. There are, I've got slides on this, but you can basically get that for yourself. There are single process theories, which suggest that there's only one of these things happening, and there are dual So here's one that says that there's a theory that the anesthetic agent binds to the proteins and prevents synaptic transmission that way. There are also dual process theories. This is my favorite. This is a dual process theory that says that anesthetic agents inhibit excitatory neurotransmitters and potentiate inhibitory neurotransmitters. And again, you think, well, like what else is there, right? It's not going to potentiate excitatory transmitters. You'd be awake, right? It's not going to inhibit inhibitory neurotransmitters, again, because you'd be awake. It's got to be something like that. But we really don't know how these things work. And as I tell every class, just to kind of get you motivated, there is probably a prize in Stockholm waiting for the person who figures this out. Unfortunately, Morton himself didn't get the prize. He didn't live long enough to see the prizes announced. Okay, so let's now just kind of set aside the issue of how anesthesia works, because we don't really know, okay? And talk about how it is we know that the patient really is anesthetized. How do we know that the patient really is unconscious? Clinically, this is done. This assessment is made mostly by means of behavior. The anesthesiologist will do what he or she does to induce anesthesia, and then will give the patient a verbal command. If you can hear me, move your finger. If you can hear me, wiggle your toe. And if the patient doesn't move the finger or wiggle the toe, then you can assume that the person is adequately anesthetized. This, of course, is before the muscle relaxant is delivered, because once you've delivered the muscle relaxant, the patient's not in any position to be able to wiggle a finger or wiggle a toe, but they're aware of this. Then the anesthesiologist will monitor the patient to see if there are any signs of awareness of pain during the procedure. For example, does the patient start tearing? I'll talk about that more in a second. And then later in the recovery room, the anesthesiologist or a nurse anesthetist will come around and do a little interview with the patient post hoc to ask if the patient was aware of pain or aware of anything else during surgery, if the patient has any kind of memory during surgery. Until very recently, this was how anesthesia was assessed, purely clinically, purely in terms of the subject's the behavior. And it turns out that anesthesia does a very good job of eliminating awareness in surgical patients. Far fewer than 1% of surgical patients report any kind of awareness during surgery. Even if you just survey malpractice claims, there's hardly ever a malpractice claim where the patient says that he or she was aware during surgery. The possibilities of surgical awareness despite anesthesia, they're not zero, however. There are certain kinds of surgeries where you don't get complete loss of consciousness. Cesarean sections often are done under a very light plane of anesthesia because nobody wants to take a chance that the anesthetic agent will be toxic to the fetus. Trauma surgery is often done with minimal anesthesia, and the reason for that is in trauma surgery the person's got loss of blood, low blood pressure, and they're not able to maintain the anesthesia. Same reason for bypass surgery, certain forms of heart surgery, where the patient's blood pressure goes relatively low. And then finally in neurosurgery. Neurosurgery is usually done without a general anesthetic because when you're poking around in somebody's brain, you want them to be able to say what's happening when you do that. But for most general for most general surgical procedures, balanced anesthesia is what people do, and it works like a charm. Yeah? It means you're not really completely out of it, right? So think about anesthetic depth, okay? You're not very far under. And again, this is very common. Probably the most common application is in obstetrics with cesarean section. Okay, now we have other techniques for monitoring awareness. Some of these are more or less indirect. In cases where the anesthetic agent is a gas that's delivered by means of an inhaler, nitrous oxide and oxygen or isoflurane or enflurane, there is a set of standards called the minimum alveolar concentration, and basically that measures the amount of the anesthetic agent that comes out when the patient expires, not dies, but exhales, right? There have been studies done over the years that determine what's known as the minimum concentration of anesthetic in the patient's air supply that's necessary to achieve certain kinds of anesthetic goals. So, for example, what's known as MAC, minimum alveolar concentration, is the minimum amount of the minimum dose of anesthetic that is required to prevent movement in response to stimulation. And then there's called MAC aware, which is the minimum amount of anesthetic that eliminates awareness of stimulation, not just response to stimulation. This is a measure that's very analogous to sensory thresholds. So you take a group of patients, actually normal subjects who do this for pay, and you give them the gas, and then you determine what level of concentration eliminates response or eliminates awareness in 50% of the subjects. And so there's this level, MAC, the minimum alveolar concentration, and what anesthesiologists will try to do, those who are using an inhaled anesthetic, is to keep the patient at a level that's just a little bit beyond 1 MAC, okay, about 1.3 MAC. They assume that is an adequate amount of anesthesia. And again, by virtue of the reports of patients afterwards, that's a standard that works. That's a pretty indirect way of measuring anesthetic depth, however. There's no measure of consciousness here. They're just looking at inputs to the patient, how much gas the patient is given. So there is another a technique that's very common in operating rooms known as the PRST score. And this is a measure of consciousness that makes use of autonomic nervous system indices of conscious awareness. So P stands for blood pressure. They monitor your blood pressure. If the patient's blood pressure starts increasing, they start thinking, oh, they're starting to feel something. They're starting to feel pain or anxiety. Same thing with heart rate. They'll monitor the patient for signs of sweating. Never mind that there are very intense surgical lights over the patient. You can see when the patient starts sweating abnormally. and also the secretion of tears as an autonomic response to stimulation. And again, what you want to do is to keep these 4 indices as low as possible. And again, this is kind of clinical behavioral signs of anesthesia. There are also a number of signs that measure the activity of the central nervous system more or less directly. Let's look at one of these. One of these is known as the event-related potential. We've talked about this a little bit before. This is a wave in the electroencephalogram that occurs in response to a momentary stimulus. And you'll remember that it has this characteristic shape to it, and we think that the early components, the first 10 milliseconds after stimulus onset, seems to reflect activity in the brainstem. The next 90 milliseconds or so in the what's so-called middle component of the event-related potential seems to reflect activity in subcortical areas of the brain, like thalamus or whatever. And then finally, after about 100 milliseconds or so, you're getting activity that seems to reflect cortical processing of the stimulus. And what will happen often in surgery is that the patient will get a little a stimulus device attached to his or her wrist that delivers a very, very weak electrical shock to the wrist, and they'll then monitor online these event-related potentials. And what you're trying to do, if you're doing that, is you want to reduce the so-called cortical components of the event-related potential. These late components, after about 100 milliseconds, keep those minimal while leaving these pretty much intact. So again, on the theory that the late components of the event-related potential are representing something closer to conscious activity, conscious processing, or at least cognitive processing of the stimulus, it makes sense that you want to keep those down. So that's one way of doing it. Another way using central nervous system indices is to monitor what's known as the EEG power spectrum. Again, this makes use of the electroencephalogram, which, when it was first observed, was just a single wave that reflected the electrical activity of the brain. But we now know that that single wave reflects a whole bunch of different waves that are underlying that can be decomposed by mathematical techniques like Fourier analysis that we don't have to go into, and I couldn't go into if you held a gun to my head. But in any event, we now know that the standard EEG can be decomposed into at least 5 different bands that differ among themselves both in the frequency of the wave and the amplitude of the wave. So the waking EEG is composed of a mix of alpha activity, kind of slow, high amplitude waves, and beta activity, faster, low amplitude waves. That's what the waking EEG looks like. As we'll see next week, when you fall asleep, you start getting a lot of delta activity in the EEG. This very slow, regular rhythm. And then there's also this gamma band, which a lot of people pay attention to. So what can happen now is that there are, with advances in medical technology, we can monitor the patient